So we are going to start with this lecture on CNS infections, and I'm going to share the screen with you, and then we will start off with the lecture, right? So I hope you can see the screen. And in this lecture, we are not going to cover many different infections. We will just restrict ourselves to meningitis. And in meningitis, as you will see, we will do only bacterial meningitis. So the lecture objectives and outcomes are, we will refer to the latest guidelines for treatment of meningitis. We'll not go into the details. I'll just give you the reference to these guidelines. We will have a brief review of the pathophysiology of meningitis and a brief review of the clinical presentation and diagnostic tests. Now, among the diagnostic tests, you do not have to go into a lot of details, but whatever is important, I've written that it is important and you should know that. Then there will be a general overview of pathogens involved in community-acquired meningitis. You need to know that. Primary and alternative treatment options for community and nosocomial meningitis, and that, of course, is the most important part. And then there is workup and management of bacterial meningitis. And the focus of this chapter is on bacterial meningitis, okay? I usually say that workup and the procedures and the pathophysiology, that is just preparing the ground for the treatment. So the most important part is the treatment in all the lectures in therapeutics. So this is one example of the guidelines, European Society of Clinical Microbiology and Infectious Diseases. So these are the guidelines, and these guidelines were published online on 7th of April, 2016. And before that, the last guidelines were published in 2007. And in the past decades, the epidemiology and treatment strategies for community-acquired bacterial meningitis have significantly changed. So that means there might have been some change in the bacteria or some fungi or viruses that may cause meningitis. Now, these are the guidelines of the Infectious Diseases Society of America, and their guidelines were published in 2017. Practice guideline for healthcare-associated ventriculitis and meningitis. And meningitis may not only be acquired in the community setting, but may be associated with a variety of invasive procedures or head trauma. So that's an important point to remember. And when there is head trauma or invasive procedures, obviously, the microbiology is going to change. It is the Staph aureus that will enter the picture in these situations. In nosocomial meningitis, a different spectrum of microorganisms that is resistant gram-negative bacilli and staphylococci is more likely the etiologic agent. Right, sorry, I'm going the wrong way. All right. So, moreover, healthcare-associated ventriculitis and meningitis are representative of the diverse mechanisms that include placement of devices that can lead to these serious illnesses, okay? So infections of the nervous system can be divided into infections of the meninges and of the brain tissue, right? So when we say meningitis, that's what we are going to do in this lecture, and which is the most common form of brain infection. That means the inflammation of the meninges. So you can have acute bacterial meningitis, which involves the subarachnoid space. So I hope you know a little bit of anatomy of the brain and its coverings, the meninges. We can get viral meningitis, encephalitis, which means the infection of the brain tissue itself. So it is confined to brain tissue. And we can get focal infections such as empyemas, brain abscess, subdural empyema. It is a localized place in the subdural space. It does not involve the whole of the subdural space. And all of these, including meningitis, they present as non-specific fever and headache. And in healthy individuals, they are usually diagnosed when altered consciousness, focal neurological signs, or seizures appear. So the presentation of meningitis or central nervous system infections could be variable, right? And I said that the most common presentation is fever and headache. Now, the key goals of management are to distinguish between these conditions, identify the responsible pathogen that you do with CSF examination, and initiate antimicrobial therapy. Now, the classification of meningitis, it is a clinical syndrome characterized by the inflammation of the meninges, dura, arachnoid or subarachnoid space. Meningoencephalitis. The meninges, subarachnoid space, the brain parenchyma are involved in the inflammatory reaction. Acute bacterial meningitis consists of an acute purulent infection of the meninges and the subarachnoid space. So mostly, it is the subarachnoid space where we have got a lot of structures and blood vessels, and we have got the cerebrospinal fluid over there. So that's where most of the time the infection occurs. It may result in decreased consciousness, seizures, raised intracranial pressure, and stroke. All right. So I hope if you remember, we discussed the difference between convulsions, seizures, and epilepsy in the lecture on epilepsy. So epilepsy is a chronic disorder, whereas seizure is an electrical abnormality or disorganized electrical activity in the brain, which could occur in epilepsy and many other situations like brain tumor or a meningitis you have seen over here, or they could occur in high-grade fevers as well, particularly in the babies. And convulsions are muscular movement, but anyway, that is besides the topic. The following factors can be life-saving in acute infections of the nervous system. So early recognition is very important. Efficient decision-making. You must quickly make a decision whether to enter the antibiotics and how to enter or administer the antibiotics. And you see rapid institution of the therapy. But we have to be careful. We have to take into consideration many factors before administering the antibiotics. But early diagnosis is very important. Non-bacterial meningitis, it could be fungal and parasitic forms. We're not going to those details because they are not as common as bacterial meningitis, but there are many etiologic agents like cryptococcal meningitis, histoplasma meningitis, right? Then aseptic meningitis, we have a slide on that. In these cases, a cause of meningitis is not apparent after initial evaluation. So that is why we call it aseptic, whether it is bacterial or viral, although in most of the cases it is viral. These patients have an acute onset, and I'll tell you what we mean by acute and subacute in a later slide. Acute onset of meningeal symptoms, fever, and cerebrospinal fluid pleocytosis that is usually prominently lymphocytic. So pleocytosis means increase in the number of white blood cells. When the cause of aseptic meningitis is discovered, the disease can be reclassified according to its etiology. And as I said, in 55 to 70% of the cases, it has a viral etiology. So viral meningitis, there could also be many different viruses, enteroviral meningitis or herpes simplex virus, and there are other examples as well. Now, types of meningitis anatomically, this is just to give you some additional information. There could be some classification I will not ask you this thing in the examination, but maybe in the other exams you have got Pachy meningitis, which means inflammation of the dura. It is less common. Then you have leptomeningitis, which means inflammation of arachnoid and subarachnoid space. Pachy means thick or tough, so dura mater is thick and tough, and lepto means sort of thin, okay? So the most common cause of meningeal inflammation is bacterial or viral infection. And if you do not treat it promptly, it may lead to lifelong disability or death, particularly in the babies. Now, as I said, acute meningitis is the one that develops in less than a day, and it is almost always bacterial. Subacute meningitis develops over 1 to 7 days, and chronic meningitis develops over more than 7 days. The signs and symptoms of meningeal irritation associated with CSF pleocytosis persist for longer than 4 weeks. So chronic meningitis, more than 4 weeks. Acute meningitis, less than 1 day. And in between, between 1 and 7 days, you can have subacute meningitis. And once again, pleocytosis means increased in the number of white blood cells in the cerebrospinal fluid. Now, what are the risk factors for meningitis? This is important for you to know from a clinical point of view, not necessarily from the examination point of view. So it occurs at the extremes of age, which means less than 5 years and above 60 years of age. Immunosuppression, like any other infection, it is an important cause, and opportunistic infections can invade the meninges. HIV infection by encapsulated S pneumonia, when S pneumonia acquires a capsule, it becomes more infective. That is a virulence factor for S pneumonia. Overcrowding, such as dorms in military or in the colleges, which increases the risk of outbreaks of meningococcal meningitis. Alcoholism and cirrhosis, recent exposure to other people with meningitis, dural defect, like in trauma, or after a surgical brain surgery, surgical operation, or it could be congenital as well. Intravenous drug abuse is a problem for all types of infections, including meningitis and malignancy. And I'll show you the bacteria. Listeria monocytogenes is one of the bacteria that is pretty common, although S pneumonia and meningitis, they are more common, but at different ages, we have different organisms that I'll show you in one of the slides, and there are many other causes, okay? So quickly, we'll have a look at the pathophysiology over here. And most cases of meningitis are caused by an infectious agent that has colonized or established a localized infection elsewhere. So it has come from somewhere in the body, and I'll show you those places, but it could be anything. It could be from your throat, from your sinuses. Potential sites of colonization or infection include the skin. Obviously, there has to be there has to be a breach in the continuity of the skin so that the bacteria enter the bloodstream and reach the brain, the nasopharynx, the respiratory tract, the GI tract, and the genitourinary tract. It could come from anywhere. And depending on the severity of bacterial meningitis, the inflammatory process may remain confined to the subarachnoid space. So subarachnoid space, where you have the cerebrospinal fluid, that is the most important thing. And that is why the gold standard for diagnosis of meningitis is withdrawal of or the examination of the cerebrospinal fluid. Now, we can get raised intracranial pressure in meningitis, and that may involve many pro-inflammatory molecules that I'll show you in the later slide. And of course, all of those include TNF-alpha and IL-1 beta, but there are others as well, like IL-6, and I'll show them to you in the next slide. And there could be mechanical events like some sort of procedures on the brain, interstitial edema obstruction of CSF flow as in hydrocephalus. There could be cytotoxic edema, swelling of the cellular elements of the brain through the release of toxic factors from the bacteria or neutrophils. Okay, now this is just, I'm trying to show you something. This, I've shown you this Buckingham Palace in this place, and you see it is very heavily guarded all around these people from the military, or I don't know where, but they're guarding, they're from all around. The palace is surrounded by these people and nobody can reach the palace, right? So the brain also has a defense mechanism. It is also protected. And I'll show you in the next slide, and I'll also ask you a question, okay? So the CNS lacks lymphatics. Well, recently it has been discovered that CNS does have lymphatics. They are known as glymphatics. I hope I'm correct. But anyway, it displays a low level of major histocompatibility complex molecules and is uniquely shielded from free diffusion of immune cells and infecting organisms by the blood-brain barrier. So my next question is going to be about blood-brain barrier. Is the blood-brain barrier like this? Yani something is protecting the brain. Let us suppose that this Buckingham Palace is the brain. So is it something all around the brain? And we'll come back to this question in the next slide. For protection, the healthy brain and spinal cord are under continual immune surveillance to detect and eliminate potential mediators of infection outside the blood-brain barrier. Now, you see these immune cells, they usually cannot cross the blood-brain barrier, right? The brain has got those glial cells and astrocytes. They are playing the major role in protecting the brain against infections. But when a person gets meningitis, the blood vessels become more permeable to drugs as well as to bacteria. And in these situations, the bacteria and even the immune cells can cross into the brain, all right? The bacteria may already be there because it is already meningitis and inflammation, right? So peripheral immune cells enter the CNS at a very low rate. And as I said, the brain has got microglial cells and it has got astrocytes, they serve a protective role in the brain. All right. So here is the question, the brain is covered by meninges. This is a thick membrane, must be durameter. And below that, we have got arachnoid, and just adherent to the brain tissue is pia-mater, which is a very thin sort of membrane. So we have got three membranes: meninges, durameter, arachnoid, and pia-mater. Now my question is, see, this is, and the question is about the blood-brain barrier. So what is blood-brain barrier? See, this is our university. If we make a bubble all around this university like this, so nobody can enter the university. So the university is protected. So is the brain protected like this? Or you see, this is a thief, there is no bubble around the university. It's just that, these meninges could be this big bubble. Or, in this case, this thief is inside the university, but all the doors are locked. Although he's inside the university, but he cannot steal anything because all the doors, all the labs, the library, the classrooms, which has got the multimedia and the furniture, everything is locked. So he is inside the university, but he cannot do anything. He cannot enter the actual the actual classrooms. Okay, so how is the blood-brain barrier like? Is it like this surrounding the brain, which is these meninges, or is it like this? So the answer to this question, we discussed that in the classroom. The answer is, it is like this. These corridors, they represent the blood vessels. So the bacteria can come into the blood vessels. The blood vessels are everywhere in the brain. because the brain needs a lot of oxygen and the nutrients, and they go through the bloodstream. So they are everywhere. So the bacteria can enter, the drugs can enter, but they cannot cross into the actual brain tissue. They cannot go out of the blood vessels because of the tight junctions of the endothelial cells in the blood vessels, right? So that is what I wanted to show you, because many students do not have a very good concept of blood-brain barrier. So it's not something like this. It is not something surrounding the brain. It is not these meninges. They do protect in case of head injuries if they themselves are not damaged. But what we call the blood-brain barrier is the blood vessels, which are everywhere in the brain, even the capillaries, but nothing, these, I mean, nutrients and oxygen and gases can go in and out, but bacteria and drugs and many things cannot cross that. And that is why they are in the brain. They go all around the brain, but they cannot leave the blood vessels, just like this thief cannot leave the corridor, he cannot enter the classrooms. So those things cannot enter the actual brain tissue, all right? So cytokines and secondary mediators in bacterial meningitis. Bacterial meningitis increases CSF concentrations. I mean, there is, yes, there in the CSF, there are increased concentrations of TNF alpha, IL-1 beta, IL-6, and IL-8. So these are the characteristic findings, but we don't look for these things. You know, we look for other things like the proteins, the sugar, and the bacteria, the immune cells in the CSF. That I'll show you in the later slide, and that is a very important slide. Aseptic meningitis, again, you will have increased levels in the CNF of TNF alpha, IL-6, and interferon gamma. These mediators are released by the endothelial cells, by the leukocytes, by the microglia, by the astrocytes, and meningeal macrophages after exposure to bacterial products. You know, the bacteria sometimes they secrete toxins, and those toxins can stimulate the immune system, or that the toxins can also damage the cells and the blood vessels. And amplification of inflammatory reaction is caused by IL-6, IL-8, nitric oxide, prostaglandin E2, platelet activating factors. So many things, you know. You have done this in your pathophysiology in the chapter on inflammation. Okay, we showed you a lot of chemical mediators of inflammation. So the net result of above processes is vascular endothelial injury and increased blood-brain barrier permeability, leading to the entry of many blood components into the subarachnoid space. Okay, so that is the problem. Vascular endothelial injury and increase in the permeability. Now, this increase in permeability, it allows certain harmful components to enter the subarachnoid space, but it also allows certain drugs that are not usually able to go into the brain. So when these blood vessels are dilated, they become more permeable. Those drugs like penicillins, cephalosporins, they can cross into the brain. And you know, there are some drugs, they can always cross the blood-brain barrier, like rifampin, right? But these drugs like penicillins, they can cross the blood-brain barrier only when the meninges are inflamed. Now, bacterial seeding of the meninges usually occurs through hematogenous spread. So we said that infection could come from anywhere, from the genitourinary tract, from the GIT, from the skin, from the nasopharynx, sinuses. You know, they come through the bloodstream. Many meningitis causing bacteria are carried in the nose and in the throat, and they are the normal commensals over there. They are asymptomatic. I mean, they don't cause any symptoms. Most meningeal pathogens are transmitted through the respiratory route, including Neisseria meningitidis, which is also known as meningococcus, and streptococcus pneumonia, which is also known as pneumococcus. All right. Certain respiratory viruses are thought to enhance the entry of bacterial agents. You see, we discussed in respiratory tract as well. When there is viral infection, it prepares the grounds for bacterial infection, because in the respiratory tract, the viral infection will impair the this escalator, this cilia and the mucociliary escalator. Sorry, I forgot that. So the mucus and the cilia, they are working all the time in the respiratory system to move the sputum up and take out all those bacteria and polluted material with them. And a similar thing happens in the brain. The viral infections enhance the entry of bacterial agents into the intravascular compartment, presumably by damaging the mucosal defenses in the blood vessels. Okay. Once in the bloodstream, the infectious agents must escape immune surveillance. And that happens, obviously. That is why we get these infections, like we have done sepsis last time. Sepsis also means invasion of the bloodstream by the bacteria, and that leads to this dysregulated immune response, right? And there is also a term bacteremia, which means bacteria in the bloodstream that could be asymptomatic, but it can reach the brain and cause meningitis, okay? Once inside the central nervous system, the infectious agents likely survive because host defenses appear to be limited in the CSF. We said that the immune cells, they find it difficult to cross the blood-brain barrier. So that is why, these bacteria or these organisms, once they are in the subarachnoid space, they have an opportunity to divide and spread, okay, unchallenged, because there are not many immune cells over there. So causes of meningitis include bacteria, viruses, fungi, parasites, and drugs. For example, non-steroidal anti-inflammatory drugs, metronidazole, immunoglobulin, IG, whatever. Common bacteria in various conditions are in HIV infection, you can get Mycobacterium tuberculosis, syphilis, cytomegalovirus, Listeria monocytogenes. And you can get bacteria in trauma or neurosurgery. Staph aureus is there, S. pneumonia, enterobacteria, and Pseudomonas aeruginosa. Ventriculoperitoneal shunt. This is a shunt that is placed in the brain in cases of hydrocephalus. So this is Staph epidermidis, Staph aureus, enterobacteria, and Propionibacterium acnes. Okay. Then pachymeningitis, there is an abundant pus in the dura, most often develops after skull fracture or sinusitis. Okay, this is usually staphylococcal or streptococcal. So we can have different types of bacteria depending upon the situation. Okay. Right, common bacteria that cause meningitis, these are Streptococcus, group B Streptococcus, which is Strep A galactiae, which is most common in neonatal, newborn, 1 to 4 weeks. Neisseria meningitis is common. Haemophilus influenza is common, but the incidence of H influenza has decreased because of the vaccine. We have a vaccine for pneumococcus as well. So it has gone down since the introduction of Haemophilus B vaccine, HIB vaccine. HI stands for Haemophilus influenza B vaccine, right? Listeria monocytogenes, aerobic gram-negative bacilli, staphylococcal meningitis, right? So all of these are the most common bacteria that you will see in other slides as well. So S. pneumonia, a gram-positive coccus, you already know that. It is catalase negative, is the most common bacterial cause of meningitis. So S. pneumonia is alpha hemolytic. Just to recall a little bit of microbiology, alpha hemolytic means partial hemolysis. There will be a green color around the colony. Okay. In addition, it is most common. It is the most common bacterial agent in meningitis associated with basilar skull fracture and CSF leak. Okay. And when there is basal skull fracture, sometimes the CSF can be seen flowing out of the nose, okay, out of the nares. Strep pneumonia is a common colonizer of human nasopharynx. It is present in 5 to 10% of healthy adults and 20 to 40% of healthy children. So it's a normal commensal over there. Now, meningococcal meningitis has the initial picture that I showed you, the baby or the toddler, he had some spots under the skin, which are known as purpura. So this is one of the bacteria that can cause non-blanching purpura, okay? So N meningitis is a gram-negative diplococcus that colonizes the nasopharynx, just like pneumococcus. Recent viral or mycoplasmal infection has been reported to disrupt the epithelial surface and facilitate invasion by meningococcus. Currently, N meningitis is one of the leading causes of bacterial meningitis in children and young adults, but the incidence has decreased with the use of conjugate meningococcal vaccine, right? So it is one of the leading causes, or it is the leading cause, but the incidence has gone down because of the vaccine. Aseptic meningitis, I've already described to you. It is one of the most common infections. The only thing is we have not been able to identify the organism. That is why we are calling it aseptic meningitis. Unfortunately, up to 86% of cases of aseptic meningitis in adults have unknown causes, since molecular diagnostic techniques and arboviral serologies are underutilized, or the facilities are not available in the medical facility where the patient is taken to or where he is admitted. If appropriate diagnostic methods are employed, a specific viral etiology is identified in 50 to 60% of cases of aseptic meningitis, and most of them are viral cases, as I mentioned earlier. However, aseptic meningitis can also be caused by bacteria, fungi, parasites, and I think I've already mentioned some. It is noteworthy that partially treated bacterial meningitis accounts for a large number of meningitis cases with negative microbiologic workup. So that is, when you treat, you must give treatment for a sufficient period of time that we will discuss under treatment, right? So this slide, causes of aseptic meningitis. I mean, I've given you a lot of bacteria. I've given you important bacteria. So here I give you bacteria, parasites, fungi. And these bacteria, I said that Listeria monocytogenes is important. And then these other ones, they are not very common, right? The ones that are very common, I've already shown them to you. I'll show them to you once again. So you can keep this slide for your reference, okay? But this slide this is also just for your reference. It shows you many different types of viruses that can cause aseptic meningitis: enterovirus, herpes virus, paramyxovirus, Toga virus, flavivirus, Bunia virus, so many viruses, okay? So you can keep this slide for your reference. And chronic meningitis, the bacteria are important over here, okay? Mycobacterium, Borrelia, Burgdorferi, Treponema pallidum, Brucella species, Francisella, tularensis, that comes from the rabbit, if you remember, Nocardia, Ectonomyces. These, if you want, you can memorize these bacteria for chronic meningitis, okay? But this is the slide which is very, very important. You must know this slide, okay? This gives you the common bacteria in different age groups. For example, newborn to 4 weeks, it is Strep A galactiae. Group B, Streptococcus, okay? We have group A, hemolytic, which is Pyogenes, but this is group B, okay? These are beta hemolytic. Beta hemolytic means they cause complete hemolysis. There will be a clear zone around the colony when you grow them on blood agar. Okay, so E. coli are important. Listeria monocytogenes is important, but S. A. galactiae is very important. 4 to 12 weeks, again, A. galactiae is there, but we have E. coli, H. influenza, strep pneumonia, and Neisseria meningitidis, So you see A. galactiae, H. influenza, S. pneumonia, meningitidis. These are coming again and again. 3 months to 18 years again, meningitis, strep pneumonia, H. influenza, 18 to 50 years, S. pneumonia, and Neisseria meningitidis, H. influenza, same thing, bacteria. Age more than 50 years, again, S. pneumonia and meningitis, Listeria monocytogenes is there. Now we get aerobic gram-negative as well. Immunocompromised, with these, we have got aerobic gram-negative as well. You see, S. pneumonia, meningitis, monocytogenes. These are there, coming again and again. Here it's a little bit different over here. See, intracranial manipulation or neurosurgery. This is an invasive procedure, right? There are instruments that are going inside the brain. So you can get Staph aureus or coagulase negative staph, which are epidermidis and saprophyticus, if you remember. Aerobic gram-negative are there again, including Pseudomonas. Okay, so things are becoming a bit more serious over here. Now, basilar fracture, we have got, again, S. pneumonia, H. influenza, and group A streptococcus. Group A streptococcus is strep pyogenes. Okay, and then CSF shunts, right? Again, Staph aureus. So these ones you should know. These are important. I've given you the important ones that occur most commonly. These ones I've given you once again, and they were there in a previous slide as well. Now let us go on to the prognosis and complications. Advanced bacterial meningitis can lead to brain damage, coma, and death. 50% of patients, in 50% of patients, several complications may develop in the days to weeks following. That is the problem, Long-term sequelae are seen as many as 30%. And what are these long-term sequelae, right? It could be hearing loss, cortical blindness, paralysis, muscular hypotonia, particularly in children or babies, seizures. Seizures could be damaging to the brain if they are prolonged, okay? Or if they are recurrent, frequent recurrence of seizures could permanently damage the brain. Psychomotor retardation, which is slowing of thoughts and movements, right? So all these things could occur in some unfortunate patients despite treatment. So it depends on your management as well as the luck of the patient. Sometimes even with the best treatment, complications do occur, okay? But that doesn't mean that you should not do your level best. You must give the best possible care to the patient. Right, so clinical presentation, we will quickly go through the clinical presentation, and then we will take a break, okay? So history is very important. As in any other disease, 44% of adults with bacterial meningitis exhibit the classic triad: fever, headache, and neck stiffness. These symptoms can develop over several hours or over 1 to 2 days. In large prospective study, 95% of patients had 2 out of the following 4 symptoms: fever, stiff neck, headache, and altered mental status, right? So most important symptoms. Other symptoms could be nausea, vomiting, these are important. Sleepiness, which is something like altered mental status. Confusion is also altered mental status. Delirium, coma is an advanced state of altered mental status, right? Irritability could be there, and this photalgia and photophobia, discomfort when the patient looks into bright lights. All these things could be there. Meningitis causes CSF fluid changes, and these changes can be used as diagnostic markers of infection. So clinical presentation varies with age. This is an important point for you to remember. The younger the patient, the more atypical and less pronounced is the clinical picture, right? So it becomes a little bit difficult in the babies, but it's not that difficult, you know. You can diagnose that if you take a good history and examine the patient very carefully, and you are working on obviously in a infectious disease ward, so you commonly see these things. Physical examination, non-blanching petechiae and cutaneous hemorrhages may be present in meningitis caused by N meningitis. So the picture that I showed you in the beginning, maybe it's there once again. So N meningitis is the one that most commonly causes these non-blanching. Non-blanching means when you press them, they don't turn white. You know, sometimes you press the skin or some discoloration of the skin, it turns white for a little while and then it comes back, but they don't turn white, okay? Then H. influenza, S. pneumonia, Staph aureus, they can also cause these non-blanching petechiae. We can get arthritis, inflammation of the joints in meningococcal meningitis or pneumococcal meningitis. Infants may have the following: bulging fontanelle if the volume is normal, if the fluid volume in the body is normal. You know, sometimes babies can get dehydrated very quickly because they have a very large amount of water in their bodies. Paradoxic irritability, which means remaining quiet when stationary and crying when held, okay? High-pitched cry, hypotonia, not very specific signs, but these could be there, right? So this is a normal fontanelle. You know, it closes at 18 months of age. You can feel that on the baby's scalp, you know, if you lightly touch with your finger, you can find this fontanelle. So what happens in meningitis, you see, it is bulging because there is increased intracranial pressure, more CSF, more fluid in the subarachnoid space. So the fontanelle is bulging. So that is one of the signs. And clinical signs and symptoms in young children, they can include apneas, which is temporary cessation of breathing. Purpuric rash, you know, that's the picture I showed you. This is non-blanching, which means if you roll a glass of water, you know, or it will not turn white, okay? It will remain the same color. Convulsions could be there, seizures could be there. So then quickly through the lab work, when the diagnosis of meningitis is strongly considered, lumbar punctures should be promptly performed. The most important test, okay? This is the one you should know, and examination of CSF is the cornerstone of diagnosis. So what do you do in the CSF? You do complete blood count with differential. You can do a metabolic panel with electrolytes, and you do glucose always, okay? And certain other, you know, it's given over here, serum electrolytes, then serum glucose, BUN or creatinine, liver profile. You know, a metabolic panel is not actually in the CSF. Metabolic panel is a different test where you are looking at serum concentration of electrolytes and glucose. Okay, so that is where we have got a comprehensive metabolic panel, and we have got a normal metabolic panel as well, right? So these are the things that you check in metabolic panel. Coagulation profile and platelet count for suspected disseminated intravascular coagulation. This is an important slide. See, okay, so I've written important over here. So if I ask you something in the examination, don't complain later on, okay? So you must know everything in this slide. I've explained to you during the lecture. You should know it. Now, just one or two things I'll explain it to you because we are doing bacterial meningitis. It's only in bacterial meningitis that you'll have a very high number of white blood cells, 1,000 to 5,000, you know, and no other viral, fungal, tuberculosis, you don't have this high number of bacteria. Then you also have a high number of neutrophils. You don't have anywhere else, okay? Then protein is elevated. Well, it's elevated at many places, but glucose is very low, right? So your diagnosis is based on all of these four factors and these parameters. The glucose is low because there are a lot of bacteria, they are using the glucose. So normally in the CSF, you should have 50 to 60% of blood sugar level. If your blood sugar level is 100 milligram per deciliter, then in the CSF, it should be 50 to 60 milligram. That is normal. But if it is lower than that, that means it is not normal. Okay, so you can measure CSF lactate if it is less than 35, greater than 35 in bacterial meningitis and less than 25. So lactate is an important test. You can do that. All right. So these are the needles that can be used for obtaining CSF. There are different types of needle. Some of them cause less headache with a traumatic needle. So these are some clinical points, depends which one you use. This just shows you that the patient has to bend down, so that the vertebra, the vertebral spines, they open up a little bit, and then you can pass the needle between L3, L4 space, okay? You have to go below L2. Then in babies, you can do it like this, right? So up to 50% of patients may receive antibiotics before a diagnosis of meningitis is made, delaying the presentation. This happens in all infections. If you start antibiotics, then it causes some problems. So it is generally recommended to obtain the specimen for culture and sensitivity before initiating antibiotics. Prior antibiotic therapy may cause gram stain and CSF culture to be negative, but the antibiotic therapy rarely affects CSF protein and glucose. So that's an important clue we can get from protein levels and glucose levels. These are some clinical signs known as Kernig's and Brudzinski's sign. They're not important for us, okay? And that is all for this session. And we will start treatment in the next session, all right? So thank you very much, and I will stop here.